live.
Okay. A very good evening to all of you. I welcome you all in this webinar on which is a masterclass by none other than Dr. Tariq Ketamish. And we have with us our president, Professor J.S. Tityal, who is the chief and professor of ophthalmology, the Cataract, Cornea, and Refractive Surgery Services at RP Center, AIIMS, New Delhi. He has numerous publications, loads of experience in the field of cornea, cataract, and refractive. He has received numerous awards, both international and national, and has numerous orations all over the country. He was the first Indian to have performed live cataract surgery at the ASCRS, and he has received the most coveted Padma Shri from the government of India by the President of India. So that is something, he is definitely a wonderful teacher as well, and a great human being. So we welcome our President, Professor Tityal. Dr. Namita.
It is a pleasure to welcome our dear friend, Dr. Rishi Mohan, who is the Vice President of Indian Society for Cornea and Keratorefractive Surgeons, and also the founder secretary of the organization. And he has numerous academic awards from his own college, from where he did his graduation, undergraduation, Maulana Azad Medical College, and he's been a gold medalist throughout, and also the best resident in RP Center. And he's held numerous positions as key leadership role, which include the Secretary of the Ophthalmic Research Association, the Joint Secretary of Delhi Ophthalmological Society, Member Scientific Committee of AIOS, Member Managing Committee of AIOS, Joint Secretary of Eye Bank Association of India, Treasurer Eye Bank Association of India, President Delhi Ophthalmological Society, and now currently Vice President ISCRS. So welcome, Dr. Rishi Mohan.
We also have with us our treasurer, the treasurer of ISCRS, Dr. Rajiv Mukherjee, who is also Vice Chairman of FBS AIOS. He is the Director and Senior Consultant of Mukherjee Eye Clinic, New Delhi, and a visiting professor at the Feinberg School of Medicine, USA. He is an established cornea and phaco surgeon, has many presentations and publications at both national and international levels. So we welcome Dr. Rajiv Mukherjee.
It is my pleasure to welcome Professor Ritu Arora, who's been a teacher to all of us, Dean, Maulana Azad Medical College, New Delhi, former Director, Guru Nanak Eye Center, New Delhi. She was trained at RP Center, All India Institute of Medical Sciences, both in her graduation and post-graduation, has numerous publications in international peer-reviewed journals, did her fellowship from Wills Eye Hospital, Toronto, and has P.N. Berry Fellowship as well. She's been conferred AO Achievement Award, Noel Moines Oration by Cochin Ophthalmic Society, Was Oration by the Women Ophthalmology Society, ISCRS Appreciation Award, and very recently she's also been given the FRC Opt from London, and she's also an examiner for the same exam. So welcome, Dr. Ritu Arora.
We also have with us Dr. Bhaskar Srinivasan, who is a young, dynamic cornea surgeon, has done his MBBS from Mumbai University, Mumbai, and has done his master's from the Armed Forces Medical College in Pune. He is an expert in cornea and external eye disease. He has done his fellowship from Shankar Nethralaya, Chennai, and now working as a senior consultant, Shankar Nethralaya at Chennai. He has again participated in various national and international conferences and has many good publications to his credit. So we welcome Dr. Bhaskar Srinivasan.
It is a pleasure to welcome our very dear young colleague, Dr. Sharon De Souza, Senior Consultant in Department of Cornea and Refractive Surgery Services, and coordinates the Ocular Surface Clinic at Narayan Nethralaya, Bangalore. She did her medical education from St. John's Medical College in Bangalore and completed post-graduation in ophthalmology from the same institute, did fellowship in cornea and refractive surgery from Narayan Nethralaya and observership at Singapore National Eye Center, has many national and international research publications, and is invited faculty at numerous international and national level conferences, And her areas of interest include ocular surface disease, lamellar corneal surgeries. She's a surgeon par excellence, as well as keratoconus and refractive surgeries. And currently, she's also pursuing a PhD course. So nice to have you here, Sharon.
We have with us Dr. Namita Sharma. It's a great pleasure to have her in this webinar, who is the chairperson of the scientific committee ISCRIS and also the professor of ophthalmology in the Cornea, Cataract and Refractive Surgery Services at RP Center, AIMS. She is the secretary of All India Ophthalmological Society, regional secretary, Asia Pacific Academy of Ophthalmology, secretary, Eye Bank Association of India, and has numerous publications to her credit, many textbooks, many chapters in textbooks, has been actively involved in academics and academician par excellence. So we welcome her. I'm Dr. Rajesh Sinha, Honorary General Secretary of ISCRIS and professor in the field of corneal lens and refractive surgery services at RP Center, AIMS, New Delhi. Now a few words about our speaker, Dr. Tariq Katamish, who is currently head of the cornea and refractive surgery services at the Al Noor Eye Hospital, Cairo. He has loads of experience in the field of corneal surgery. His area of interest is lamellar corneal surgery, and that is what he's going to speak today. He has been invited guest speaker in many conferences all around the globe, be it EUCornea, be it AO, be it Keracon, ISCRIS, and many more. And it was difficult to get time from him for the webinar because he had constant engagements, and he's a wonderful speaker as well, a great surgeon. He has held various positions. He was professor and former head of ophthalmology at the Cairo University, and he has been organizing various workshops regarding lamellar corneal surgery, whether it is anterior lamellar corneal surgery or it's a posterior lamellar or a DSEC or a DMEC. So it is a matter of great honor and pleasure for all of us to have him here in this wonderful webinar, wherein he will be talking to us about tips to perform a successful deep anterior lamellar keratoplasty. And before we actually start the scientific presentation, I request our president, Professor J.S. Tityal, to speak a few words.
Thank you, Rajesh. Indeed, it's going to be a terrific evening of academic, you can say, exercise, which we have been doing for so many months now, regularly on each Fridays. And definitely like to thank Tariq for accepting our invitation, and like to welcome you, sir, for this webinar of the international quality which our viewers going to have today, and wish all our panelists, the faculty, and the people who are joining us today a happy group up, because that's a festival today. The India is celebrating today the birth of Guru Nanak today. I think looking into the lamellar keratoplasty, I think we all people today who are doing corneal surgery like to get expertization in various lamellar procedures. And we understand one of the most difficult surgery in cornea is achieving a deep lamellar keratoplasty successfully, so that we have absolutely clear interface and regain the corneal anatomy in such a way gives the best visual quality possible through these cases who are having a disease in a stroma or anterior part of cornea with normal corneal endothelium. I think most surgeries in early days were in a full thickness surgery for these disorders. And these lamellar keratoplasty, the understanding of achieving a good, clean Descemet endothelial complex in these cases have changed the outcome. And we all like to aspire to become a good anterior lamellar corneal surgeries, because posterior corneal lamellar surgeries, people have easy access and they can achieve good results. But anterior surgery requires a terrific experience. And we all know, despite doing hundreds of surgery, you still get difficult situation on table. And I've seen Tariq presenting his videos, wonderful videos, his teaching has been very effective for us to translate into a deep anti-laminar keratoplasty in many difficult cases also. Thank you again, Tariq, and Rajesh, again, thank you for getting him for our this webinar. Thank you again. We can start.
Thank you, sir. Thank you, sir. So now I request Dr. Tariq Khatamish to share his presentation and tell us about the tips that make a DALK surgery successful and easy in our practice.
Good afternoon, everybody. I'm very touched by your compliments and your nice words, and I'm very happy to be with you in this prestigious webinar of the Indian Society of Cornea and Keratorefractive Surgeons, and to be among all these distinguished faculty and chairpersons. So I'm very happy to share my humble expertise with you today. So I will start sharing my screen now. Is it clear now?
Yeah.
Okay. I will speak today about the tips for executing the perfect big bubble DALK. The steps of big bubble DALK has too many steps. The first step is centration, and then doing partial thickness terrafination by suction terrafine, and then injection of air and getting the big bubble, and then debulking of the stroma by stroma dissection, and then opening the roof of the big bubble by the brave slash, and then cutting the remaining stroma by right and left corneal scissors, and then taking care of the donor, stripping its descent membrane, and finally suturing technique, whether interrupted or continuous suture. Of course, the most important steps, all these steps, is the big bubble formation. There is a lot of tips and tricks throughout these steps, so I will go step by step and trying to mention the tips and tricks in every step. So full thickness cornea replacement is not accepted anymore, except in a very limited indications. So the indications of DALK, as Professor Titial mentioned, is any case of normally functioning endothelium. The most important of them is, of course, keratoconus and post-basic ectasia, and superficial and stromal opacities and dystrophies. So all of us are familiar with the advantages of DALK over penetrating keratoplasty. There is no endothelial rejection. There is no graft failure. It is an extraocular procedure and the short-term use of steroids because there is no rejection, and the stronger growths due to biomechanical properties. And there is a very important advantage of DALK, that it expands the pool of potential cornea donors. We can utilize lower quality donor corneas for DALK, and we can use one donor for 2 transplants doing DALK and DMEC using single donor. And the last advantage, in my opinion, is the learning curve is in spite of being tough learning curve, but it goes without complications. So this is a concept of corneal splitting the cornea into 2 grafts, the anterior graft, epithelium and stroma for DALK, and the posterior graft, descent membrane epithelium for DMEC. And you can use the DMEC graft on the same day, or you can even transfer it to another hospital. This shows the concept of easy learning curve from the point of view that whenever you have any complication, you can turn the case into a penetrating keratoplasty, so there is no complications during your learning curve. So the DALK operation has always known to have a tough learning curve. However, in the next 40 to 45 minutes, I hope that I can share with you lots of tips and tricks, which in my opinion, will help you achieving the perfect big bubble DALK. The DALK operation, we can do DALK whether by the hydrodissection techniques or the viscodissection techniques. For myself, I prefer the air dissection technique, or what we call it the big bubble DALK. So the idea And the secret of success is to inject air very deep in the stroma, very near descemet membrane. So we inject air in the stroma. Gradually, the tension will build up until at a certain pressure, we will notice detachment of descemet membrane in the anterior chamber in what we call the big bubble formation. So there are a lot of tips and tricks, but there are 4 major tips. The first tip is how to get the big bubble consistently, not once and you miss it in other few cases. The second important tip is how to differentiate between type 1 and 2 big bubbles. The third tip is how to diagnose some tricky situations. And the fourth tip is how to open safely the big bubble roof. As I have mentioned, there are a lot of tips, but these are the 4 major tips. And I will go through the different steps starting from the centration. The first step in any DALK procedure or any keratoplasty procedure is marking the cornea center. So spend a few minutes for proper centration. Use whatever way you need and avoid eccentric trephination, especially in keratoconus cases. My preferred way is to fix the caliper and make a mark from nasal, temporal, superior, and inferior limbus. And the center of this square is the anatomical center. As you see, it is perfectly centered. But be careful. Sometimes if you don't spend some time, you may have a very easily eccentric trephination, as you see from this video clip. Trephin adjustment. First of all, you have to be familiar with your trephin. So you have to be familiar with the different parts of the trephin. You have to be familiar with the concept of each quarter turn clockwise rotation for the trephin make a cut of 60 micron. And you have to be familiar with the 0 position in which the blade is aligned with the vacuum chamber. At this position, when you rotate the trephin clockwise, it will start immediately cutting through the cornea. So this is the body of the trephin, the outer tube, and this is the inner tube, which is called the vacuum chamber. And the innermost part is the surgical trephin or the sharp trephin. And what I mean by the 0 level is you have to have the trephin aligned or adjusted with the vacuum chamber. So spend few minutes for trephin adjustment. As you see from this clip, this is the trephin and this is the vacuum chamber. So you have to put your trephin at the 0 mark, and some advise a 3/4 anti-clockwise rotation to have space for the vacuum to build up. So the third step of the operation is the partial thickness trephination. How many quarter turns I am supposed to do? Is it a standard depth in every case? No. The answer is no. It is variable from case to case. This depends upon the cornea thickness. So if you imagine this is the cornea, and this, the site of trephination is usually about 8 millimeter. So you have to take different corneal thickness at site of trephination, and then you take the thinnest pachymetry to be in the safe side. And then you take again 80% of the thinnest pachymetry for safety reasons. And then you divide this number by 60. And this will tell you how many quarter turns you are supposed to do in every case. Again, what is important is the thickness at site of trephination and not in the corneal center. So this is how we do it, looking to the pentacam map and calculating the thinnest location at site of trephination. So this, every trephin has its own instructions. The rules I have mentioned applies very well to the Baron trephin from Katina and JEDMED trephin. Of course, I have no any financial interest in these devices. But for example, from Coronet, it needs another calculations. So you have to know your trephin quite well, and you have to be familiar with it to have the proper depth and not to penetrate the anterior chamber. So after making your calculation for For each specific case, you go and making terrifination as usual, and you have to check the depth. You see, I will open the groove now, and I am checking that I have reached a very deep terrifination. This is one of the secrets of to have the big bubble consistently in every case. So not only the femto laser can reach this deep level, but a simple manual technique can do so. The aim is to go up to 80% of the corneal thickness, again, at site of terrifination, not corneal thickness at center. The big bubble formation, this is a major step of the operation. And the formation of the big bubble is the key step in any DALK technique. And I will spend some time in this step only. So the secret of success, as I have mentioned, is deep placement of the cannula. Again, the cannula and not the needle, because the needle is very sharp and it may make premature injury descent membrane. So this is my way of doing the injection of big bubble. First of all, I define, now we have done a very deep groove, but we need to place the injecting cannula deep as well. It doesn't make sense that we did a deep groove and then to inject superficially. So our aim is to make a deep groove. This is the first aim. The second aim is to inject in the very deep part of this groove. So this is my way of doing the job. We define the deepest part of the defined groove by making minimal lamellar dissection by crescent knife. And then I'll start doing the first ½ millimeter of my tunnel by a small nick by sharp insulin needle. And then I go by a blunt spatula very deep in the stroma and making my tunnel. And then the last step is going by the blunt spatula, 27 gauge with a 5cc syringe, very deep in the stroma, and then injecting the air. And if you follow these small tips, you will be having the big bubble as you see immediately, especially in keratoconus cases. Again, you define the deepest part of your groove. You have to inject very deep. You will make the first ½ millimeter by a sharp insulin needle, not more than ½ millimeter. Then blunt spatula, making a deep tunnel. And then by your blunt cannula, go further in the tunnel to have the space tight along the cannula, and then inject air. And as you see, it is always a reproducible technique. So the first step is how to get the big bubble consistently. Look carefully at the pentacam map. You have to look to the thinnest corneal thickness at site of terrifination. You have to know how to adjust terrifine at 0 mark. You should make a very deep terrifination. You should inject air very deep as well. And you have to use a blunt cannula and not the needle anymore. As you see, if you follow these small tips, you will be having the big bubbles immediately from the first injection, especially in keratoconus patients. So as I have mentioned, it is always a reproducible technique. Moreover, the aim not only getting the big bubble from the first injection, but immediate bubble formation without even stromal emphysema. You see these 4 examples, you inject, you will be having the big bubble immediately without even any stromal emphysema. You notice the transparent big bubble in the center. This means that you are injecting very deep near your target. So this is confirm my concept of injection very deep is a very important during big bubble formation. A good sign and tip is the sudden release of resistance of your spatula. You notice now when you are advancing your spatula, you will find it will jump in front of you, because you see this sudden release of resistance means that you are in the deeper plane. As you know, the deep stroma has not much resistance like the anterior stroma. So when you see this small tip, sudden release of resistance, you feel comfortable that you are in the proper plane, as you see from these 2 examples. You inject now and having the big bubble immediately. So what are the signs of big bubble formation? Number 1, the circular well-defined edge. This to be differentiated from the intrastromal air which is white and has a feathery edges. The second important sign is you should have rise of intraocular pressure. And the third surest sign is the small bubble test. This is what I mean by the well-defined circular edge, as you see. There is no big bubble without this very well-defined edge. In the contrary, stromal emphysema has feathery, irregular edges. The small bubble test, the idea is if you have the big bubble in the center, so if you inject a small bubble in the anterior chamber, this will be trapped in the periphery because the center is occupied by the big bubble. So this is example of doing the small bubble test. You will be having the small bubble in the anterior chamber in a kidney-shaped configuration. Another example of having the small bubble test positive. A third example, you will notice that when you inject the air in the anterior chamber, you will notice that the air is trapped in the periphery. If you don't have the big bubble, the air will move in the center. So this is a very important sign, especially for the beginners, to do the small bubble test. A very important tip also is sometimes you find a resistance for bubble enlargement. As this situation, you see there is resistance of big bubble enlargement. You see this sector is not enlarged yet. So you have to keep on injecting until the edge of the bubble come across the terrifying edge. Sometimes if you have resistance in getting the big bubble, you can stop injecting air and do paracentesis, because the paracentesis will make the pressure behind the bubble less, and this will encourage the bubble to expand, as you will see now, and go back again and inject again. You will find that the bubble will expand and go across the terrifying edge. The formation of big bubble may come from the first injection, as I have demonstrated. It may come after 2 injections or 3 injections, or sometimes you may inject as much as 5 injections. So this example of getting the big bubble from the first injection, especially in the straightforward keratoconus cases with no scarring. And this example of the getting the bubble from the second injection, this in the old days while I was using the needle, and this is the feathery edges, but now you got the bubble from a second injection with this well-defined edge. You may have the bubble after repeated injection, as this example. This is the first injection, just stromal emphysema, nothing more than air in the stroma, the tension is still soft, injecting again in the same site, again, nothing, just soft tension, making a third site, deeper site, and injecting again also no more than emphysema, and tension is still soft, making lamellar dissection, going to a 4th injection. Notice carefully now, the big bubble will form now. Now you got the big bubble after the 4th injection. So you have to be patient and determined, and don't lose the hope that you will get the big bubble. But what if the big bubble formation is impossible, either due to intraoperative complications or as a preoperative decision in some special cases like keratoconus with previous hydrops and trauma with deep scars? So you have to have the manual dissection in your pocket in this situation in which you are not able to get the bubble. The manual dissection technique, the starting point, again, you have to go to 80 to 85% depth terrifination. You have to define the deepest part of the groove, and you have to start your dissection. I like mostly the spiral technique by using the scissors. As you see, I'll go by a blunt tip scissors, making a spreading action and trying to make pocket in the cornea in a spiral direction. And in each spiral turn, you will find that you are entering another deep plane. As you see, you are entering deeper planes and going by blunt dissection, by cross action of the blunt venous scissors until you reach very deep, and you will find there is no resistance to this blunt dissection. After this, you start making the peeling off technique. You see, when you are going deep, peeling will be very easy to continue your dissection. As you see now, you are peeling the stroma from the remaining of the cornea, and sometimes you may need some sharp dissection by crescent knife to continue your technique. So you have to be always ready, and you put the manual technique in your pocket in the case you fail to have the big bubble. The third step is how to diagnose tricky situation. There are some tricky situations. I will describe two of them, what I call the collapsing big bubble, and I will discuss later in my talk what I call the premature or the unintentional opening of big bubble roof. So this one of the tricky situations is a collapsing big bubble. Watch carefully this video. When you inject, you will find a well-defined edge, but the air is escaping. I will do it again in slow motion. The tension is still soft. You see in slow motion, you have the big bubble type 1 with a very well-defined edge. But when you are going out, the air will escape with you. So the bubble is actually collapsed. And when you do the small bubble test, you will find it is negative. So there is some confusion how there is a big bubble and how the small bubble test is negative. But because the bubble have been collapsed. Another example to show this tricky situation, when you're injecting, it's a very well-defined edge. This is a for sure big bubble type 1. But look carefully, the air is coming out while you are going out with the cannula. So I am confused now. Is there a bubble? The small bubble test is negative. How come there is a bubble and the small bubble test is negative? So as you see, when you inject again, the bubble is there, but hidden or collapsed. And the solution for this situation is you go and inject viscoelastic, which maintain the big bubble space. Another third example for this tricky situation, look carefully for the big bubble edge. It is dense white edge. You see this dense white edge, and when you come out, it fades out. You see this by slow motion, a dense white edge, and when you are coming out, this white edge fades away because the bubble have been collapsed. A fourth example, again, you have a very well-defined edge, big bubble, but when you are going out, the bubble is collapsing out, and this is the cause of the collapse. You have a leaking track. So why it is crucial to recognize such situation? Because as we know, in the ordinary cases, we open the roof of the big bubble, but if we don't recognize that we have a collapsed or hidden big bubble, we will go to open the roof, we will injure descent membrane. So we have to be familiar with this tricky big bubble, and you have to deal with it accordingly. Otherwise, you may injure descent membrane by yourself. So I think this article by Professor Herman Derdouan, in my opinion, make a revolution in our understanding of the mechanics of big bubble. These are the corneal layers anatomy, and the introduction of this sixth layer described by Professor Dua, which has a strong attachment at 8.5 millimeter, make a clear understanding of the mechanics of the big bubble there. So the second tip or the third tip is how to differentiate between type 1 and type 2 big bubbles. So this video animation shows big bubble type 1. It usually starts from the center to the periphery, as you see, and it has a maximum diameter of 8.5 millimeter. This is because of this strong attachment of dual layer to the stroma. And as you see, the plane of separation is between the stroma in front and dual layer behind. And this bubble is characterized by having a very well, a white edge. This characteristic white edge is peculiar to type 1 big bubble. When you remove the stroma during the operation, you will be having the floor formed of 3 layers, endothelium, desmet, and dua. And the dua layer has characteristic rough surface, as you see from this video clip. This characteristic rough surface is of dua layer. Again, characteristic white edge, as you see, and characteristic rough surface after delaminating the stroma. Again, the white edge is very apparent in type 1 big bubble, and the rough stroma, the rough layer of dual layer is very clear. So these are typical big bubble type 1s. These again, 3 different big bubble type 1 with their characteristic white edge. If we go to type 2 big bubble, or what we call it the predesmatic bubble, the story is completely different. It usually starts from the periphery to the center, as you see now. Why? Why it starts from periphery to center? Because as you see, there is fenestrations of dual layer in the extreme periphery of the cornea. So when we inject air, the air will escape through these small, tiny holes in the periphery, and the big bubble type 2 will start from periphery to center. So again, it starts from a periphery to center, and it has a large diameter. It may reach up to 10.5 millimeter. And the plane of separation is between the dual layer in front, and descemet membrane behind. That's why we may call it the predesmatic big bubble. When we inject air, we will find the edge is clear. This also a characteristic to big bubble type 2 is the characteristic clear edge, as you see from this video clip. When you remove the stroma, you will be having the floor, fragile floor formed of 2 layers only, endothelium and descemet membrane. And as you know, descemet membrane is featureless or very smooth if you compare it to dual layer, which is very rough. So again, this is a big bubble type 2 with characteristic clear edge. And after removing the stroma, the smooth surface of descemet membrane. A third example, a glassy edge. We call it sometimes the glassy big bubble, and the smooth surface. And these again are 3 examples of big bubble type 2 with its characteristic glassy edge or clear edge. I will go now to what we call the mixed big bubble. Sometimes we have mixed big bubble, complete big bubble type 1 in the center, and another partial big bubble type 2 in the periphery. If we go further in complicated mechanics, you may have a central complete big bubble type 1 and another complete big bubble type 2, which is a very rare occasion to have 2 complete bubbles behind each other. So this, the first example of complete big bubble type 1 plus partial big bubble type 2, you see this after opening the big bubble type 1, you will be having this small big bubble type 2 in the periphery of the case. But when we come now to the complicated mechanics of having 2 complete big bubbles, one behind the other, look carefully for this very rare video. You see now, this is the big bubble type 1. But when you keep injecting, you will be having another edge. This is big bubble type 2, making the first brave slash. You will be having another big bubble behind. You see the layers of the cornea is as if it is a textbook picture, opening the brave slash, second brave slash, and you will be having the all layers of the cornea now. Another example of 2 complete big bubbles behind each other. This is after injection of air, making the first brave slash, and you will find another big bubble behind, another brave slash, and this is a dual layer. Of course, not our aim not to remove the dual layer, but this was done just for demonstration. Again, this is as if it is a textbook showing the anatomy of the cornea. So this showed the difference between type 1 and type 2. Type 1 has a rough surface, and type 2 has a very smooth surface, as you see. Dual layer is very strong. If you can do it again in slow motion, this is by mistake. I have hit the dual layer by the sponge. You see how much pressure is applied, and still you don't have rupture of this very strong layer. So dual layer is a very strong layer, and it gives the surgeon the sensation of safety during the operation. This strong behavior of dual layer encouraged me to do what we call triple phaco DALK, doing DALK through the dual layer, as in this case. This is the case of cataract and keratoconus, and making DALK through making the phaco through the dual layer after having the big bubble, making all the maneuvers of the phacoemulsification through this tiny layer. On the contrary, type 2 bubble, it ruptures very easily, as you see. Look to the arrows. Any gentle trauma will rupture a type 2 big bubble. I will speak now about what we call the burst big bubble. Sometimes if you are injecting and making too much pressure, you may have the big bubble to burst in the anterior chamber. So don't use too much pressure during air injection. As in this case, watch carefully. After the big bubble have been formed, it will rupture in the anterior chamber and air will escape in the anterior chamber. So this is an example of what we call the rupture or the burst big bubble. And sometimes you may hear the clicking sound of this rupture. Two another examples, this big bubble type 1, and then it will rupture in the anterior chamber, you see? And this what we call partial burst big bubble. There is tiny rupture which allows some air to escape, but still the air is trapped in the anterior chamber. So there was a tiny rupture in the descemet membrane, which make this burst big bubble. So the idea is when you have some small tear in descemet membrane or a very weak area, it may not be able to withstand the pressure, and after formation of the bubble, the air will escape in the anterior chamber. So we'll go further in the operation. We go to the step of paracentesis. It's a very easy step, but there are some tips during this step. First of all, you have to do the paracentesis in a vertical orientation. We are accustomed to do horizontal paracentesis while doing phaco, but here you have to do vertical paracentesis, and you have to have this opening large enough to use it for a saline injection or for air injection, not a minute opening. So this, what I mean by vertical orientation, if you are doing phaco, you are doing horizontal paracentesis, you may injure the big bubble if you are doing it horizontally, but you should do it in a vertical orientation to avoid heterogeneically rupturing your bubble. So this is a big bubble type 1. You go to the extreme periphery and go in a vertical orientation and make your paracentesis. Be careful if you are dealing with a big bubble type 2. As you see, this big bubble type 2 is large and there is no space for paracentesis. And watch carefully, it will expand. When you make paracentesis, the pressure will be low inside the eye and the bubble will expand. So this expansion may be inadvertently hit the super blade. So you have to be careful to be in the extreme periphery and in vertical orientation. Watch carefully what will happen now. So go very peripherally, vertical orientation. When you open, you will find the edge will expand. You see the edge expanding. Another example of expanding big bubble, you see, watch carefully this video. You see the big bubble is expanding. So you have to be very careful. Otherwise, you may hit the big bubble by yourself. Lamellar corneal dissection is a very easy step. Nothing important to mention in this step. The aim is just to debulk the cornea, not to go very deep, just debulking to prepare for the next step, which is a brave slash. But sometimes you may have a lot of emphysema. Making a violet mark may help you identify the cornea from the periphery of the cornea. So how to diagnose tricky situations? As I have mentioned, I have spoken about collapsing big bubble. There is another tricky situation, which I call it the premature or unintentional opening of big bubble roof. What I mean by big bubble roof opening, after removing the stroma, we go with a super plate to open the roof of the big bubble to enter the space of this bubble and to make dissection of the remaining stroma. So sometimes while you are doing stromal dissection in the very beginning, notice now you will open the roof. This opening is unintentional, of course. So you have to stop and look carefully for this tiny opening, and you can inject a cohesive viscoelastic to reform again the big bubble space, as you see in this example, reforming again the big bubble space. Sometimes you may have this premature perforation in the middle of your way. You see here where you are making the section, you have entered again the big bubble space. So you have to change your strategy, stop and define your plans and change your strategy and continue the section. And you have to be careful and you have to observe this premature opening. Sometimes you will have this in the last half millimeter of the section. Look carefully for these red arrows with the small tiny bubbles here in the periphery of the anterior chamber. Notice now these bubbles will move centrally. You see, it moved centrally. This means that you have opened the big bubble. So you have to stop and you have to enlarge and to look for this tiny opening and you continue your operation. Why it is crucial to recognize such situation? Again, we are accustomed to open the big bubble with a full space, but if you have a premature opening and you don't recognize it, you can go and open both the roof and the floor by the brave slash. So be very careful, and you have to recognize such premature opening. The fourth tip, the major tip, is how to open safely the big bubble roof. So this is what I mean by the big bubble, and this is the roof. We want now to open it by a sharp object. I usually do it by the super blade, which we call it the brave slash. So we have to make a safe opening, not to injure this membrane. And we have also to have this opening large. It should be large enough for the further step. If you have a tiny opening, you will be stuck and you will not be able to continue your operation. So our aim in this step is to have a safe opening without injuring this membrane, and it should be large enough to continue your operation. So this is an example of a large opening of the big bubble, another brave slash. A good tip here to allow time for your hands to draw your hands is to put a cohesive viscoelastic over the surface of the stroma, and you make your brave slash. This will slow down the egress of air out of the big bubble, and you will give you some safety. Another example, look carefully, putting a viscous material over the surface of the stroma, and when you open the roof now, you will be having the bubble coming very slowly. You see, this will allow you to withdraw your hand, and it will give you a safety margin of not injuring this membrane. Sometimes, as I have mentioned, you do your brave slash, but you find that you are stuck with a very tiny opening. You see, this is a big bubble, and making the brave slash, you are hesitant, not brave enough, and then you make the brave slash. But you are looking for this tiny opening, but it is not apparent. So you have to enlarge, you make magnification, looking by a blunt spatula, here and there, again, enlarging again. Sometimes it took me 20 minutes to find this tiny opening until you will find the plane, because you are not allowed now to use any sharp object. You have to do it by a blunt object. So this tiny opening is a very bad situation. It will make further steps difficult. As you see, finally, I have found my plane and I have rescued my case. Sometimes when you are doing the brave slash, you are doing a small opening and you are not sure whether you have done the brave slash and you have opened the big bubble or not. So you can go and confirm by a small bubble test. So until now, it's not opened yet. So go again and open your roof by the brave slashes. So what is the ideal big bubble roof opening? This size is the ideal size. You see, this is the ideal size. You can go from this size and use your blunt tip scissors and continue your operation. But if you have a tiny opening, you will be stuck. This is another example of the large ideal big bubble opening. You see, big bubble, brave slash, and you have a large opening that allow you to go safely without any resistance and continue your operation. These are some of the brave slash as I always say, don't be afraid. The space between the roof and the floor is not small. It is very good one. If you are hesitant and ended with a small opening, you will be stuck in removing the remaining stroma. The 8th step of the operation is crochet, incision, and stromal cutting. You either have two ways. You either go and inject a viscoelastic inside the big bubble space and make cutting of the remaining stroma using right and left scissors, but I don't like this way because this viscoelastic, it is an extra tool, no need for it. And if you don't wash it thoroughly, you may have double anterior chamber. I prefer now doing it dry technique, knowing the dual layer is very strong. I go directly in a dry technique using the blunt tip scissors, right and left, and exciting the remaining stroma, and there is no need to put viscoelastic. So look for this neat DALK wounds. This DALK wounds made by manual technique. The wounds, as you see, is very neat. As I always say, these neat DALK wounds do not differ too much from the amazing femto-laser wounds. It only requires some surgical skills and good quality instruments. The 9th step is donor tissue stripping. It's a very simple step. You catch the stroma at certain point and you keep rubbing at a certain point. Don't change the rubbing in different direction. Keep rubbing at certain point until you have descent membrane coming to you, and you can peel it as you see. Again, make rubbing at a certain point and don't change this point until you find the descent membrane, as you see. And as I always say, don't waste the chance during your DALK learning curve to do stripping of descent membrane as if you are doing DMEC. So this is a chance for you to learn half of the DMEC operation without any stress while doing DALK. The last step is the graft suturing. It doesn't differ any from the penetrating keratoplasty. You may use the continuous technique or the interruption techniques, but be careful of inadvertent descent membrane perforation. And if you have any perforation at this step, you have to put air inside the anterior chamber to guard against the double anterior chamber. Finally, as you can see, DALK has lots of tricks, but if you follow these steps and advices, I am sure you will be able to execute the perfect big bubble DALK. Thank you very much for your kind attention. And again, I am really honored to be with you today. And I am happy to participate in this webinar. And I'm always looking to join any activity of the Indian Society of Cornea and Keratorefractive Surgeons. Thank you very much. Thank you.
Thank you, Dr. Catamish. That was really one of the best presentations on DALK that I've heard. It was mind-blowing, very well explained, every tip, and it was really fantastic. Would like to have comments from the panelists. Professor Talsa?
Yeah, I would thank you. You know, it was a wonderful presentation and a lot of teaching tips, which small things can make a huge difference in a big bubble surgery. And understanding was made so clear. It is always wonderful to see his videos, which has a clear steps for everybody to understand. Very beautifully demonstrated. As far as just one query in terms of doing post-op treatment for these patients after you do a DALK in a keratoconus patient, what is your regime for these patients for a subsequent rehabilitation? Because after doing DALK, you rightly said in the beginning, the steroid requirement will be less compared to the penetrating keratoplasty. But how do we manage these patients subsequently for a visual rehabilitation? What is your...
My post-operative regime for these cases is topical antibiotics for 10 days maximum, no more than that, and lubricant and artificial tears for 1 year until the full regeneration of the corneal nerves. And as regard the steroids, I'm using prednisolone 1% eye drops 5 times per day for 1 month, and then gradual tapering during the first 5 months. So I'm using it 5 times per day in the first month, 4 times per day second month, etc., until I reach once per day at the 5th month. I was beforehand, I was using topical steroids for only 1 month, but I have noticed some reactions and some what we call stromal rejections, and some more expert surgeons than me advised me that I should use steroids for a larger period of time. So I'm using now steroids for 5 months. But of course, it is forgiving. If I have any troubles with prednisolone, for example, rise of tension, I can shift very quite easily to fluoromethylone eye drops. It is forgiving. It is not necessary as if you are dealing with a case of penetrating keratoplasty.
Thank you. Thank you. Yeah. Any other question from the other panelists?
Yeah. Professor Ritu, ma'am?
Yeah. I enjoyed his talk because I could identify at every step, everything which one has gone through. And I have interacted with him so many number of times, and he's given me those tips, which have definitely benefited me. But there are few questions which I still have. I mean, I have seen all your videos when you're doing DALK in keratoconus cases or post-LASIK keratoectasia. Any difference when you're doing DALK and say simple corneal opacity, nodular keratopathies, or say lattice corneal dystrophy, so there also do you get the bubble so easily? Suppose you have a, say, 1/3 corneal opacity only, superficial corneal opacity. So there, if you start doing DALK, do you also get the bubble so easily compared to how you get keratoconus?
Yes, this is a very, very good question, a very important point. Of course, in my opinion, the getting the big bubble in keratoconus cases is much easier than in corneal scars. To my opinion, if the keratoconic cornea, the type of collagen is a very weak cornea, and the spread of air is very easy. It can open the space very easily to have the bubble. But with corneal dystrophies and scarred corneas, the percentage of success in having the big bubble is less than in the straightforward keratoconus patient, but still you have a good chance of having the big bubble. And the incidence of big bubble type 2 is much greater in these cases, especially when you have a post-herpetic scars or post-acanthamoeba scars, because again, in my opinion, with the scars, you have the space between dual layer and the stroma is obliterated by the scar. So there is no way for the air to make the big bubble except going behind the dual layer and making the big bubble type 2. So to summarize my answer, it is possible to have the big bubble in corneal scars, but the instance of success is less than the big bubble type 1. And you will find that you will have more big bubble type 2 than the straightforward keratoconus patients.
Second point which I wanted to make, that though you've shown beautifully using those vacuum trephines, so in our Indian setting, at times the cost of vacuum trephine comes in, So we very often resort to using simple, manual trephining.
Yes.
And if you have any tip to use, because using vacuum trephine adds a cost of 10,000 rupees for me for every.
Yes, I know, of course. So unfortunately, I am stressing of the value of the vacuum trephine, because this is the only way to have a guarded trephination and you to reach as deep as you want. But if you are doing it by the handheld trephine, you will not be able to judge carefully the depth of your trephination. So I think this step is very important, that you should use the vacuum trephine. But if you said if it is not available or it's somewhat expensive, So you will do it just a terrification, which I think you should do.
What I do here is that I do make some kind of a mark with my manual trephine, and then I deepen it with a diamond blade.
But again,
of course, it's very rough.
You cannot reach as deep as you want exactly. You will be hesitant. You are afraid to perforate. But this is a good tip, but it will not give you the accuracy of using a suction terrifine.
Yes, true. Third thing, once when I interacted with you regarding the formation of a big bubble, you told me all these three things, that using an insulin needle and then using a spatula and then using a cannula. So I have tried using it. I don't know, maybe the others also could answer that. I've tried using it, but very often what I find that the spatula which I've used, and when I put my 27 gauge cannula through that, somehow the cannula, the air leaks out from there. It is not so snugly fitting into that whatever spatula what you made. So the bubble does not come out so easily at that time, So you poke in with the insulin needle, I have got that kind of a pointer where I poke it with that, and then I do enlarge it with a spatula. But I do get at times into things. So somehow I am still comfortable using my usual 30 gauge needle and with the deep entry. But the trick which you said, that you are very consistent in making a big bubble. So maybe other people could also opine if they have any.
I will demonstrate this point. The trick is you should have your spatula exactly the same gauge or diameter like the injecting blunt cannula. For myself, I go to the any conference, I go to the exhibition of any instruments, I catch the cannula in one hand and the spatula in the other hand, and under the microscope, I am sure that they are identical. Because if the spatula is slightly larger than the cannula, you will be having a leaking track. So the cannula will not fit snugly in the stroma. This is a first important point. The second point I didn't mention in my talk, and when I make the tunnel with the spatula, and when I go with the rounded cannula, blunt cannula, I go further in front. I make the tunnel slightly further to have the space snugly fit around the tip of the cannula. This to avoid the leakage of air. The third solution for this situation is you can make the first 0.5 millimeter by inch needle, and you can go directly by the blunt cannula. You can skip this step of the spatula if you find any problem. But this is the way I am doing.
It doesn't go in so easily.
Yes.
I'm just telling you.
I think I agree with you, ma'am. We are more used to doing it with the needle and find that, that gives you a tighter kind of a fit. And cannula, we've tried several, but doesn't kind of work. And of course, if you do have a IOCT, you can actually make out the depth. But even if you don't have, you can actually, figure out what the depth is by, even we are using refines which are, not guarded. So you have to, by proprioception, only gauge at what level you are. And then with the help of the diamond blade or the blade breaker or the 15-degree blade, you have to then make a neck and then...
Again, because this way it leads to how Dr. Tarek said that you lead to consistent big bubble. With the technique, which if I go with my needle and all, I am not so consistent, Like 80-90% I'll get a big bubble. First there is some emphysema, then there is a big bubble. But the technique which you described, it's like almost doing a clean fake,
Actually, ma'am, the issue is of the spatula. So once we go through the needle, most of the cannulas that we have will be of the same gauge that we can use the needle and the cannula together without using the spatula.
Yes. I agree with you. You can omit the step of the spatula, but it works in my hands very good, so I don't want to change my technique. But if there is one of my colleagues asking me from where to get the spatula, I tell him it's not that important. You can go directly by the cannula and inject.
And another thing I have noticed that very often, at least in my DALK cases, you had a nice DALK, absolute big bubble, nice, everything suturing done, everything perfect case. But 8 to 10 days later, you find some kind of epidefects coming in, so some suture tight here. So I have found the epithelial related problems somehow a little bit more in my DALK cases. If you've also got it, I don't know where I'm going wrong. And I was reading it somewhere that it is commoner in DALK cases because sometimes we don't use a good quality tissue, or maybe.
Yes, this is the point. This is the point. Yes.
So, but
I think this is the point. This is because of the quality of the grafts, not because of the DALK operation in itself. Mm-hmm. So, in spite of using low quality cornea will work, but I'm still insisting on using a good quality cornea for even the DALK cases, because I have sometimes noticed that sometimes the stroma doesn't want to resolve in some DALK cases because of the bad quality of the stroma. And after changing the stroma, it will dramatically improve. So I advise using reasonable quality corneas for DALK and not to go to the low quality corneas, because we'll have some problem, as you have mentioned.
And any difference in formation of bubble you have seen in like extremely ectatic corneas, like say central corneal thickness 200, 220. Of course, you said rightly that the thickness and the type of trephination is more important. But we get here a lot of children who are 8 to 10-year-old and extremely ectatic corneas, coming to you straight away with 220, 230 microns. Vis-a-vis doing DALK, something which is like 340, 330 micron, where you can't do now. Even the DALK incidence is going down because we are doing a lot of CXLs. But if there's any difference you found in the two kind of cases?
For myself, I didn't have the chance to operate on a very thin corneas, as you have mentioned, but I don't think there is any difference if you are dealing from what concerns us is the periphery, not the center. But I may guess that if you have a case of keratoglobus with a very thin periphery, this will be difficult, and this would be the question, how to deal with such very thin corneas at the periphery. But I think that if you have thin corneas at the center, it will not make a difference in the chances of having the big bubble. And in my experience also, as regard the cross-linking, I didn't observe any difference in dealing with corneas, whether cross-linked or not. And I have shown a lot of cases with intacs, and again, I have a very big chance of getting the bubble in a case of intacs with previous cross-linking. So this is my experience. I didn't find any difference in the behavior of the cornea when it is cross-linked or not.
Thank you. Thank you.
Ma'am, I think in thinner corneas, it is easier to, the bubble comes out, there's less resistance, less tissue above it. And so it forms much more quickly than it would in a thicker cornea. In thicker cornea, invariably, you have to do some amount of debulking, and only then the bubble forms.
Because as he rightly said, Dr. Tariq, that when you put in your needle to form the bubble, you have to go quite a bit inside, at least 5 millimeter you have to traverse from the limbus. Now here, when you have a thin cornea, that traversing into the thinner cornea at least gives me a...
Oh, but then when you have the needle, you can always change the track. Number one. Number two, it's always wise to go wherever the pupil is, at the pupillary edge. So you're actually not going in the center, but you're going at one of the pupillary edges. It could be the nasal or the temporal side. And when you are right in the center at the pupillary edge, then you go and inject. I think then it's almost always sure that, you will be there.
Right.
Tariq, do you do any debulking, any of the dystrophies like,
I do. Because those corneas are thicker.
They are thick.
Debulking, yeah. Maybe doing one layer first and then...
Before injection?
Yeah.
No, the people who speaks about debulking before injection, the main point of importance for them is to go deep. But I can go deep, very deep, without debulking. So there is no reason to debulk first. And the second, if you have a thin cornea in the center and you are debulking without making any stromal emphysema, you will make a premature entry to the anterior chamber. So debulking I think has no value, and it may have some harmful effects if you dealing with a very thin cornea, and you may prematurely enter the anterior chamber.
No,
So
I didn't mean keratoconus. I just meant about some dystrophies.
Sometimes the cornea is 500 micron corneal scar. Debulking helps because then you can see what's there.
So cases like macular dystrophy, etc., it kind of helps you,
What is the value of debulking in such cases?
No, because the roof is thinner. It rises
it's easier. Rises.
It's also easier to do the cruciate incision as well as remove.
Yes, of course. I will do debulking after the big bubble. I agree with you. I have to do the debulking, but after having the big bubble. Yes. I am speaking about debulking before a big bubble.
I see.
Before. In my opinion, it doesn't have the great importance because I can go deep, very deep, even in corneal dystrophies or corneal opacities. As I have shown you from my technique, I can go very deep. And sometimes if you have a very thin center, I am afraid that to lose the case very early and to perforate the cornea if I debulk before the big bubble formation. This is my point of view.
Yeah, Sharon was saying something.
Actually, as everyone has said, it was a wonderful presentation with lots of very important tips. I think some things which have really been very useful while operating have been, one, the small bubble, which really gives us an idea, especially when there's some emphysema, you can't make out whether the bubble has released or formed. Then that small bubble really saves us. And also when there's a mixed kind of bubble, then you know by the movement of the bubble, it becomes easier to sort of assess. And that viscoelastic on the bubble before giving the brave slash to release, slow down the release of the air has really, very, very useful. One thing which I wanted to ask Dr. Katimesh and everyone here, when we have these very ectatic corneas, extremely ectatic, and then we do a DALK, sometimes post-operatively you can see wrinkles which the DM has been thrown into. So what I have been doing is sort of ironing it at the end of the case to avoid the wrinkles coming into the visual axis. But is there any other way to handle them and make it better? You get these folds of the...
I think they do disappear over a period of time. They are there.
Yes, they do. They do reduce
post-op period, and then over a period of time they do
reduce significantly. Yeah. No. So any other way to keep them off the visual axis, or just ironing is fine?
I think another tip is when you are suturing the graft, I think that you should have the bubble behind it to stretch this membrane, and don't suture in a soft situation. When you are suturing in a so soft situation, you may have wrinkles, but if you reform the tension, it will help reduce these folds. Yes, please, Dr. Raju.
Dr. Bhaskar, you have to unmute. Yeah.
So, I mean, basically the same thing. If you have a very ectatic disease, because it's a stretched DM, somewhere it is going to wrinkle. So having air bubble in when you're suturing kind of gives you the contour also to maintain your graft contour well. And even if you have wrinkles, it's more a concentration at the edge of your graft host junction, which doesn't affect the patient as such. The other point would be when you mark the instrument that you're using to make your brave slash, you can probably just mark the tip also. Sometimes just the fact that ink is there identifies the point of entry, because the most important step is actually making the mark, making the slash large enough to not get it. And that is the step which everybody fears because we are so worried about
functioning this brain.
Somebody was mentioning in between in one of the webinars that they use, say, the MVR blade kind of a thing, which is more tangential to make the nick rather than a 15-degree blade, because the plane of entry is going to be parallel to the DM rather than vertical as far as a 15-degree blade is concerned. Your opinion on that?
Yes, I heard about this using the MVR blade, or even some are advising using the keratome in a parallel situation. But I am one of the surgeons who changes their technique. Very difficult to change my technique since it's working my hand. But I agree with you that going in a parallel direction, it may give you some safety.
Bhaskar,
one thing which I found, sorry, ma'am, please carry on.
No, carry on, Sharon. Carry on.
If in case there's a very small nick, so one technique which has helped is the same blunt cannula, which if you have it handy, or something like a very narrow iris repository, if at least that can go into that small opening, and then use a sharp instrument on that to sort of de-roof over it, rather than try to nick again with a sharp instrument directly.
But the problem,
so that
the
helps.
problem is sometimes you cannot find this opening
Even
to
that.
have the
Yes,
cannula inside.
Yes.
This is very, you
Very
have
small.
to enlarge the magnification,
Yes.
very large, and
Yes.
you have to look careful. But since you find the opening, there is no problem. You will go with the cannula and make the roof above it.
Another thing which helps at that point is if you put a drop of visco, then it sort of magnifies it, and you can see even a very tiny
Good tip.
opening. So
very
that
good
helps.
One can also actually decompress the chamber and then actually use a wide bore and use viscoelastic in the area where you thought you made the brave slash and inject. And so the least resistance the visco will find and will open up that little area, and then one can then continue to expand on it.
Yes. This needs a 30 gauge cannula to have a very tiny opening, a very tiny cannula.
So I think what you said, sir, sorry, ma'am, I keep it.
No, it's okay. Sharon, continue. I'm talking about a different topic, so you continue this. Let's finish this.
So I think what everybody has said about the cannula or the needle, even I use a 30 gauge needle only for the bubble, but just going far enough into the cornea, what I've noticed with a lot of trainees is that we are so scared of the perforation that they don't go far enough into the cornea. They go just very short distance and then start injecting. And that is sure that, it's just going to get a little emphysema, or the bubble is going to come backwards. Another thing which I think really helps is understanding the bubble or how the air is moving. So the minute air is coming backwards, I tell, to stop, because otherwise that's never going to go forward and get you the big bubble. And if you keep injecting, then the whole thing will become emphysematous. Right. Also, if the air tracks around and comes into the AC, then they have to understand that it may have tracked through the trabecular meshwork. So those kind of understanding of the air and the bubble also helps in the learning curve, so to speak.
Exactly.
So how important is the position of the opening at the cannula? Is it okay if it's at the axial end, or does it have to be inferiorly placed in the air cannula for making the big bubble?
I think it makes sense that if it is inferiorly placed, it will have the air going directly to the target. So I'm using a Donald Tang cannula, which has an inferior opening. That's why they are doing it in such design, but I don't have experience if I am using cannula with a tip in the tip, hole in tip. So my experience and my logic thinking is having the hole below is of great importance. I think so.
Yeah, Rajiv, you wanted to say something.
Yeah, I must congratulate you, Tariq, and thank you so much for a lovely talk today. As
My
always,
pleasure.
As always.
Thank you.
I have 4 points that I'd like to touch upon. One, we just discussed about cross-linked corneas undergoing DALK. I had this thought process, but intraoperatively, I've done a few cases, not too many, of cross-linked corneas where I've done a DALK. It actually is pretty easy to peel off. And then in one of the symposiums, there was a discussion on this. Why is it so? Because then we realized that the line of intersection of the cross-linking zone is far away from the Duas layer. And you're actually working between the line of intersection and the Duas layer. So hence your air bubble traverses through, and your dissection with air or visco, whatever you're using, becomes very easy, even in a cross-linked cornea. You're actually not going through the cross-linked zone. So that's one
observation. This is my observation, that I didn't find any difference between cross-linked and non-cross-linked corneas.
So that's probably the theoretical explanation of the thing.
Yes.
Second is about suturing. Once we have done the dissection, we placed a stromal host donor, and we are suturing it. Sometimes due to uneven emphysematous host rim, the suturing becomes titration of tightening of the sutures becomes an issue. And that's post-operatively, suddenly we might find certain sutures becoming too tight and some of them becoming too loose. So is there any tip that you or the panel, somebody on the panel can share?
For myself, I didn't find any problem during sutures, and if I find that the tension is somewhat high and there is some tension in the suture tightening, I lower the tension by evacuating some aqueous to have the sutures tightened easy.
Now, what I want to say is the host rim through which it has become has gotten air. It's got emphysema, so that's thickened up. So
I don't think that the emphysematous cornea is thicker. I don't think so. I think it's just becoming white only. But I don't think that the air expand the cornea. This is my point of view. I want to hear the other panelists as regard this point. Does the emphysematous cornea is thicker than the normal cornea? Does air increase the thickness of the stroma at that time?
I just want to say one thing, that I feel it does make it a little thicker. And so there is some unevenness, but even the donor cornea which you're putting, and if it's not a good quality tissue, that is also usually edematous. So there is unevenness from there also and the host bed. So that titration is a problem. But I always tell, especially my residents and somebody whom I'm teaching DALK, that when we make a peripheral, when we peripherally deepen that incision, I always like to do some bit of peripheral grooving. Because then when I do the peripheral grooving through my crescent, then when you suture becomes very easy. It almost becomes like a tuck-in, because when you're in the beginning of your DALK, I've seen some surgeons rupturing at that stage also.
Yes.
Or it might be just very superficial because they're very scared to go in the depth. But so I always, at least for myself also, I like to do some bit of a peripheral grooving, so that my suturing is facilitated.
And this could be achieved. This could be achieved also by having the big bubble edge crossing the terrifying edge. You will be having this grooving with air, not necessarily to do it by crease knife.
Yes.
Ma'am,
sorry, carry on, please.
Do you mean grooving or do you mean ledge, which is there all around?
It's grooving. It's like when I'm going there, I do some bit of my crescent, like, when I'm debulking the superficial stroma, then I take that
just beyond the trifine mark.
And you follow, the needle follows.
So then the needle automatically goes.
Follows that.
It just goes automatically. So then there is no way you can, rupture. Now, sometimes I don't suture myself. I leave it to my residents. So then I'm not scared, because of time or something. Yeah. So, but earlier I would never even leave one suture to my resident, because I know you can even rupture at that time. But now
a word of caution in that one wouldn't want to do that with a type 2 bubble. If you have a type 2, you don't want to be doing groovings and
No. But this step I do only before. It's only at the stage of debulking. So that time you don't have this part of type 1 or type 2, this type 2 bubble.
So two more things I wanted to just comment upon or touch upon. Please. That I kind of noticed and figured out that when you're doing your paracentesis, you do it after injection of the big bubble.
Yes.
So a little difference in what I do, I make the paracentesis before injecting. And the reason I find it makes me comfortable is that it does not bring in the element of a restricted bubble, or even ruptured bubbles would be rarer, I guess, in a hypotenuse eye, because the Descemet's membrane has more skirt area to expand. So that's a little variation I make.
Even I injected a little bit, but there again, like last DALK when I injected inadvertently, the bubble which went in was a little larger than what I wanted to inject. Okay, I wanted to inject only a very small bubble. And howsoever hard I tried to make that bubble smaller, it was not possible. So that slightly bigger bubble, I wouldn't say it was very big bubble, slight. So that posed a problem in formation of big bubble, because there was resistance coming because of that bubble. Ultimately, I was successful. But as he was showing the slides of resistance in forming a big bubble, so one of the reasons could be if you already have a bubble in the AC.
And one thing is that, sorry, Tariq, carry on.
No, so I just want to comment on this point. I have tried to do the paracentesis first and to inject a small bubble, to use what we call the double bubble technique. But I found that making paracentesis makes the globe somewhat soft, and during introduction of the cannula and the spatula in a soft cornea, the mechanics was not good for me. I preferred to make my tunnels in the stroma in a virgin globe with the full tension. So that's why I regret using this technique, and I am insisting on obtaining the big bubble first and then doing paracentesis.
Okay. Last point I really wanted to know was, I started my DALK with visco dissection, and I once in a while, very rarely still do it. Is there any way, I mean, when I started it, there was no concept of Dua's layer, it came in later. But is there any way that a type 2 bubble can be formed with visco dissection?
To be honest with you, I have no experience at all with visco dissection. I have never used the viscoelastic for obtaining the big bubble. So I think I am not in a position to answer this question, because I have never.
I have had 2 cases with the visco bubble also, which were type 2 bubbles.
No, but why I specifically asked this question was the mode of formation or the mechanism of formation of the type 2 bubble is the air entering at the 8.5 millimeter junction. So does the visco have the fluidity to actually go through those micropores? And I mean, that is what puzzles me. I don't know.
Both the cases, the visco bubble was made because the air bubble itself was, not that big. It was small. So in order to enlarge that space or the supradesmoid membrane compartment, the viscoelastic was injected. It did form, but yes, it was a type 2 bubble, not a type 1 bubble. So initially it was with the air, but when we enlarged it, it became a visco bubble with a type 2 bubble. Another thing that I wanted to ask was that how many of us are still doing big bubble DALK in macular dystrophy? Because many people have given up doing big bubble DALKs in macular dystrophies.
I think that obtaining the big bubble in macular dystrophy is no problem. It could be obtained quite easily, but the question is the endothelium is healthy or not?
Yeah.
For myself, I have done not too many cases of macular dystrophy, and they're still with DALK, and they're still having these deposits in the desmoid membrane. But fortunately enough, they are still working. But there is a debate or controversy or whether to do big bubble DALK or penetrating keratoplasty in such cases. But for the mechanics and the big bubble formation, I didn't find any difference between macular dystrophy or stromal or any other stromal dystrophy. So this is a matter of controversy as regards the pathology, not the mechanics of the operation. So if you consider it is unhealthy endothelium, so you have to do keratoplasty penetrating. If you consider it's not that healthy, you can do DALK. This is a question, in my opinion.
And for Bhaskar, the question that I wanted to ask, in chemical injury cases for which you've already done a surface procedure and now you are doing a DALK, so are you able to get big bubble for those cases? Because these eyes are also a little hypotenuse.
Not the percentage of big bubbles is much lesser. And most of the time, the problem is, most of the time, the chemical injuries, we are probably dealing with a much larger graft. So I prefer doing a manual dissection. I don't mind having about 100 microns of tissue remaining back, because I don't want to end up having a perforation where I have to do a full thickness graft in those eyes. So especially if I'm doing a corneal spiral dissection, then I do a manual dissection. I use a combination of stromal emphysema, because it gives me a visible clue in terms of how much of tissue is still remaining back. Yes. The physical clue of your spatula moving at a deeper plane gives you a very good idea as to how deep you are. The spiral technique, which Professor Tariq showed up very well, where you can use your vanas and keep going deeper and deeper, and as like an onion peel kind of a thing, you go deep. Once you are deep enough, you try to peel. If you are able to peel, you know you are deep enough, and then you don't have to be too worried about the residual stroma, because that's in the same plane. So if it's in the same plane, the interface haze is much lesser. Yes, the visual recovery would be a little bit slower as compared to a big bubble DALK, but in the long run, 6 months, 8 months,
it works.
It probably works.
Fine. And difference in interface vascularization you have seen in cases of big bubble versus manual dissection? You know,
With
in
it
general,
does happen more in manual dissection if you have a bit of a stroma. So when you actually end up having a stromal rejection, because if you look at stromal rejection, that's also more common in chemical injuries as compared to keratoconus, where it's pretty rare. But in chemical injuries, we've seen it in about 30% patients where they do end up with stromal rejections. So there, if you actually end up seeing the vascularization at the interface, but then it's okay. You can peel off the LK, you can go at a deeper level and do it. If you've got a big bubble and you end up with the vascularization on the DM, then it becomes a problem, because then you don't have an option. You have to probably do a PK subsequently, or you have to cauterize the blood vessels at the edge and hope that the vascularization doesn't recur again.
lot of conus.
How often do you get vascularization in DM?
I have never seen.
I've seen in 3 cases. They were all 3 LKs done. So it was like first LK I had about 150 microns. Second, I went further deeper, and then finally I ended up having the vascularization on the DM itself.
I have never seen such a phenomenon.
I cauterized the edge, and I still went ahead with the DALK because it was a pediatric patient. I didn't want to do a PK, but that again had a stromal rejection. So finally, I had to do a PK in one patient where we've shown the pathology, also showing the DM, but it's not published. We just took the photo. It's not published. Probably I should publish it.
Ma'am, Ritu ma'am, you were telling.
I was just saying, because a lot of conus cases which we get in children are with VKC. They have cobblestone papillae, and eyes are very irritable. They're quite red. So their 10 to 12-year-old children will very advanced conus. So some of them said present you with high drops. So I have seen those cases when you do high drops. Of course, I do only manual. I don't form a bubble. In those cases, I see vascularization element, though I have to step up steroids. Otherwise, my long-term patients after 1 year are on a very diluted soft steroid OD-BD dose, But in these cases, I need to be, I have to be careful, because I've seen some cases who are lost to follow up, and then they come back.
Basically, they also have a lot of suture loosening. They have a lot of
inflammation,
which is the main problem. Trickling
because of the allergy. Yeah.
So you have to control the allergy, and these are difficult cases, because they will be the cases where you'll have a lot of epithelial healing issues also. They will have epithelial breakdowns. So there it makes sense to actually take a good quality tissue. Even if it's a DALK, the epithelium at least of your donor should be intact, rather than have a graft where the epithelium is peeled off.
Yes.
Exactly.
Also, in these kind of cases, I tend to add in allergy treatment like a tacrolimus ointment for these patients post-operative, and it does help a lot, because anyway we'll be trying to reduce the steroids fast, as Dr. Katamish was saying, but by then the tacrolimus covers them, and if they are already on it, then I definitely continue, because a lot of them have allergy, and there are many children with advanced KC, because of their eye rubbing and allergies. So it really helps in these patients.
Just a word of caution, at least I've had maybe 3 cases till now, maybe more than 200 DALKs which I've done, that where they had high astigmatism, vision was not coming to the desired level at 3 months, but actually they were steroid responders, and I had missed them.
Very common.
I have missed them, and they were steroid responder, and they straight away went to glaucomatous optic atrophy, So, and I'm thinking that the vision is not good because of suture related and astigmatism issue.
Yeah, every visit, the IOP definitely.
In IOP, measurement is not very reliable, So how?
Yes.
That's why this issue comes up.
Any other comment?
I think from Professor Tityal sir, we need comment.
Yeah. So final comment from Tityal.
It was very interesting listening to all the experts who are so proficient in doing DALK in all different kinds of situations. If I summarize my own journey in DALK, I had all these problems which Tarek has discussed with us, right? From the not achieving any bubble to a burst bubble to a double bubble. In fact, my first double bubble happened long time back, without knowing any anatomy at that time. It happened in a macular corneal dystrophy. I think these cases have both chances of getting a double bubble or both type 1, type 2. And Dr. Namita could gather cases from a some of our colleagues and published that series of cases. It happened before the understanding of Dua's layer and type 1, type 2 and those cases. Just one interesting discussion which happened was very extreme ectasia patients where we do DALK, where the thickness may be around 250, 280. There we are so worried about rupturing the cornea, we are quite anterior most of the time. In few cases, what I've seen, instead of getting a big bubble going posteriorly, the bubble forms anteriorly. So you have a little bit of, sort of a central, nipple-shaped type of bubble forming, and that doesn't enlarge. And after rupturing that, we have to do a manual dissection to reach up to the level which you. And that is how I completed few of those extreme cases where bubble popped up towards the central area upwards. And few cases, as we discussed, rupturing the descemetes, which happened during the dissection in earlier cases, because your plane of your cutting and dissection in 360 degrees is different in a DALK than a routine penetrating keratoplasty. And as Dr. Namita pointed out, apart from what Dr. Ritu talked about making a groove, we normally leave to like a little ledge of stromal tissue in the periphery, which is the safeguarding the, during suturing. It gives you a plane of your suturing, which goes just anterior to that layer. And a real safety for these patients are DALK in suturing cases. The initial question which I talked about with Dr. Tarek was to look into the suturing technique and suture adjustment and long-term assessment of suture, the astigmatic pattern and the rehabilitation with contact lenses or a suture adjustment removal in these cases. What I used to practice in a keratoconus cases was to make a suturing in a way which makes the tensile stent there for a longer time. So my suture would almost end up to the limbus in these cases, so that the suture strength remains for a long time in a keratoconus, doesn't let the graft to bulge out, which can happen sometimes, and you have an ectasia coming very fast in a keratoconus patient. So little modification I've done in a suturing so that I have a retention of a stent for a longer period, maybe for a few, 6 months or so that healing occurs and ectasia doesn't happen in these patients. And Dr. Rajesh knows that contact lens, we practice these patients quite early also in DALK patient, and we have not seen any untoward problems with the contact lens in the DALK patients. In fact, they do so well in large number of cases. Otherwise, I think beautifully covered. Rejection, yet we have also reported rejection in our DALK patients, which we all know they recover very fast with the treatment of a rejection. And second rejection, I'm not sure if people have reported that. We have not seen repeat rejection occurring in a stromal rejection cases. That's a good part, and endothelium remains safe in all these cases. Little bit of haziness in the interface, little haze coming in the corneal stroma, especially from the suture-related area, maybe the initial indication of rejection happening in these cases. And these patients come to us very early because their vision gets disrupted very fast, unlike in other keratoplasty patients. But I think we had a terrific discussion, and all the experts have done a wonderful inputs for this. I hope that people would be brave enough to, as we discussed, Nick has to be very brave. Yes. They have to be brave to get into our DALK procedures also, especially big bubble DALK.
I must say DALK was a boon during the lockdown time, because during the lockdown time, a lot of patients who might have done DALK, they didn't come, they didn't follow up. And so they all stayed okay. So nobody had any problem. On the contrary, some of the corneal
patients, patients,
problems, rejections. But these patients not followed up, and they do very well. So that's why it's a procedure which I think everybody should learn. And
yes, of course.
So it was a wonderful webinar on DALK and how to get a big bubble, and wonderful tips, Dr. Tarek. It was really marvelous. There's no doubt about it. And so many queries solved, so many things, so many questions, so many things discussed. I thank all the experts, Dr. Ritu, Dr. Bhaskar, Dr. Sharon. I would like to thank Professor Tityal sir, who has always guided us. Dr. Tariq, Iskeres, he's the president and he helps us.
Yes, of course.
All our activities.
Boss.
Yes, he's the guiding force. Of course, Dr. Namita, the chairman scientific committee, and Dr. Rajiv and Dr. Rishi, who are really, pillars behind the activities of Iskeres. So I thank you all. And I thank the staff, the support team, IPCA, Bageshwar, Shivam, and Anil. And of course, once again, a big thanks to Dr. Tariq Ketamish for sparing his time.
Thank you, sir. Thank you so much.
Thank you for organizing this, like always. Thank you.
It was a true masterclass.
It was a master course, I thought. It was bigger than a class.
Absolutely.
It was a grand master class.
That
is true.
I would like to thank you all again and to thank Dr. Rajesh for giving me this opportunity to be with you. And I'm very happy to share my expertise with you. And I have already learned a lot from the great discussion from each one of you. I have learned a lot, and I appreciate very much your kind invitation. Thank you very much.
Thank you.
Thank you.
Okay. Bye. Good night.
Thank you so much. Good night, everyone.
Good evening for Dr. Tariq, actually.
Yes. Good evening, everyone.
It's 4:30 or 5 o'clock, right?
Yes, it's 20 minutes to 5 now in Egypt.
Yeah.
It's three and a half hours difference between us and India. You are in front of us by 3.5 hours. I hope the next time we will meet in person in the next meeting, as I have mentioned, next August 2022.
Yes.
Okay.
Yes. I hope to see you all there.
Yeah. And we are extending our invitation to you for the next meeting in August 2022. So
my pleasure. Of course, my pleasure. Thank you very much.
Thank you.
Bye-bye.
Okay.
Okay.
Bye-bye.
Bye.
Bye.
Thank you so much.